Hello, everyone, and thank you for joining us for Season 5, Episode 28 of Doc Talks with Dr. Forrest, Tennant, and friends. We're delighted that you could be with us this evening, and we have some extenuating circumstances tonight, but still, dedication has shined through once again. You shine all the time. Dr. Tennant, it's all yours. Please take it away. Thank you.
First off, I apologize for where I'm at and having to do this over a telephone. I'm stuck in the Dallas airport because of flight problems. And so, but I do have a couple of messages I'd like to get across today. And I know Dr. Ibsen and Jimmy will fill in for me. I have two subjects I'd like to cover today. One is spinal fluid leaks. I hear about spinal fluid leaks routinely from people. And first off, let's talk about what they are. Spinal fluid leaks are of two types. One is traumatic, and that's from something like a lumbar puncture, epidural, or surgery, or a surgeon nicking the dura or something like this. It's trauma. Now, the second kind of spinal fluid leak are what we call spontaneous leaks. These occur sort of out of the blue. Somebody who has EDS and or adhesive arachnoiditis develops a spinal fluid leak. Now, the approaches to both of these are really quite different. Now, the trauma is quite obvious. You know why it's leaking, and the treatment for that these days is blood patches. That's what's done in America, or blood patches. Then they tell you to go to bed. They'll oftentimes give you an anti-epileptic medicine or an antidepressant or something like that. But the blood patches are the treatment for traumatic spinal fluid leaks. But the ones I really want to talk about are those that occur in people with arachnoiditis and EDS, because you can wake up one day and all of a sudden you've got dizziness, you can't stand, and you find out you have a leak. I want to talk about these because they are not being treated correctly, in my opinion, in the main throughout the country. Now, first off, what causes a leak if you have EDS or you have arachnoiditis? And the answer is very simple. It's inflammation. If you get the arachnoid membrane inflamed, it can eventually erode through the dura, and that causes the leak. It may just seep a little bit, or it can flow rather profusely. And that is what causes the leaks. It is inflammation, period. Now, you don't treat, and what I find disturbing is that people are going to doctors and they have a leak and they have EDS or they have arachnoiditis, and they try to treat this with a blood patch and the same treatment they're trying to treat with traumatic spinal fluid leaks. It will not work. That's not the cause. And what I'm amazed at is when I look at the cases, nobody almost bothers to realize that if you don't control inflammation, then you're not going to stop the leak. It's not going to stop if you give that person a blood patch or a tranquilizer or an opioid drug. You've got to treat the inflammation. And you're going to hear me talk a lot about this because inflammation inside the spinal canal has to almost be treated with either methylprednisolone or dexamethasone. In other words, a good first step for leakage in somebody who's got EDS or AA is a 6-day Medrol dose pack. And then you want to try to do the other measures, ketorolac, pentoxifylline, acetazolamide, diclofenac. You've got to get anti-inflammatories into that spinal fluid in order to deal with the leak. And that's not being done very often. Now, once you kind of get control of the inflammation, in my opinion, what I like is that I like the people to use the new peptides and hormones to try to regrow the arachnoid and the dura so you can stop the leak. I mean, for example, one of my favorite first treatments is BPC 157. You can get that as a tablet, as a nasal or injection, and you add that to, say, DHEA or colostrum or progesterone. You're going to get a pretty good healing effect. And so my call tonight is for people who have leaks. You're going to have to educate your doctors and anyone you come in contact with that if you have EDS or you have AA and you have a leak, it's due to inflammation, and you've got to get the inflammation stopped. Now, there's another aspect of this, and that is what's causing the inflammation. It may well be that it's the Epstein-Barr virus or an autoimmune disease such as psoriasis or scleroderma or Sjogren's or one of the autoimmune diseases. Now, I want to go ahead and now switch to the Epstein-Barr virus. We're now really into this, and I want to talk about the Epstein-Barr virus in this way. We just mentioned inflammation. I want to talk about inflammation in a way that you already know, but I want to call your attention to something. All of you know a lot more about inflammation than you think because you've had a lot of inflammatory conditions in your life. You've had a sore throat that was inflamed, the body healed it. You had inflammation around cellulitis or a boil or a pimple, the body healed it. You may have had inflammation in your lung with some bronchitis, the body healed it. So our big mystery for a long time has been, why doesn't the spinal canal heal inflammation? And it looks like it's because of autoimmune activity or possibly Epstein-Barr viral activities. Now, what I want to try to get across to everybody, and you're going to hear me talk about this probably over and over and over, but there is something about the classification of herpes viruses, again, that is known by the general public, but they're having a hard time accepting it with the Epstein-Barr virus because the Epstein-Barr virus is much more lethal than the other viruses. Now, the herpes viruses include the common herpes simplex, as well as herpes zoster, which is shingles. Now, Epstein-Barr virus is herpes number 4, but it's the only virus we know that causes such things as cancer, as well as multiple sclerosis and adhesive arachnoiditis. Now, here is what I'm trying to get across to everyone. When you first get an Epstein-Barr viral infection, or even herpes zoster, the virus may go into tissue and stay there in what they call a latent phase for a long time. Now, we know that the herpes viruses, and particularly Epstein-Barr virus, like to float around in your lymphocytes, but they will reactivate under certain conditions of stress. And that stress has to lower your immune system. Things like a severe infection, trauma, severe psychological stress, like a divorce or a bankruptcy. These things can cause your immune system to go down enough that the Epstein-Barr virus will reactivate. Now, once the Epstein-Barr virus reactivates, 2 bad things can happen, okay? And everybody out there who has adhesive arachnoiditis probably has suffered one of these 2 things from the Epstein-Barr virus, at least according to our research. And one of 2 things has happened, or both. One is the Epstein-Barr virus has reactivated, floated around your blood, and landed in the arachnoid membrane. It's a very soft tissue with no blood supply, so viruses like to grow there. So the Epstein-Barr virus during the reactivation will enter the arachnoid membrane and colonize the membrane. It'll set up a colony, and it may grow there for years, and you don't even know about it until one day you have an epidural or surgery or something else, and all of a sudden you've got adhesive arachnoiditis. Remember, the virus can reactivate when you're age 20, colonize your arachnoid membrane, and you don't even know it until all of a sudden you've got arachnoiditis when you're age 40. So remember, the virus can colonize tissues, and we think not only the arachnoid membrane, but also the intervertebral discs and maybe even the cauda equina itself. We're not sure about the latter, but we know that colonization with the Epstein-Barr virus does occur with a reactivation. I'm going to talk to you about a real case here in about 2 minutes. Now, the second thing the Epstein-Barr virus can do is cause autoimmunity. And unfortunately, it causes 2 kinds of autoimmunity. One is it causes something called autoantibodies, which floats around your blood and attacks tissue that he thinks is abnormal. But it also has the ability to take cells in the arachnoid membrane, maybe in the cauda equina, as well as in your discs or other tissues, and change the cells to where some of the cells become almost malignant. They become what we call an autoimmune cell, and they will attack normal cells. We think this is actually the mechanism as why we have chronic serious inflammation in adhesive arachnoiditis. We think the virus is either Epstein-Barr virus or some other virus has turned on cells to become autoimmune at the local level, and that's why the inflammation may remain there for life. Now, I want to switch gears for a minute and tell you about a real case. I was sent this week a case by a woman who was in her 40s, and her doctor sent me the laboratory work, and I'm going to read it to you. Now, she has adhesive arachnoiditis, and her two antibodies, the major one, it's the VCA IgG, that's known as the reactivation virus. Now, her test is above the laboratory level of 600, meaning she's reactivated at least one time in her life, if not several. In other words, we now know just looking at the test, the virus was reactivated some time ago. Now, she has her second antibody test known as the nuclear antigen. That result is 61. Now, that's about 3 times normal. That means she's probably got some autoimmunity. Now, here's the catch. The tests that show whether the virus is currently active are negative. And her doctor says, well, gee, the tests are being currently active or negative. Maybe she's okay. No, she is not. In other words, she was reactivated years ago, and now that virus may have colonized her arachnoid membrane, or it developed autoimmunity, or both, and now she has probably the result of reactivations that may have taken place 5, 10, 20 years ago. And so this is the problem with this virus. It has a long asymptomatic latent period from reactivation to the time that disease starts. So now what does she do about it? The reason I'm giving this today, and don't mind being here in the Dallas airport, is that I do have a protocol for somebody like her. One is there are a number of vitamins, minerals, and herbs that have been shown to stop future reactivation. And I think everybody who has these elevated antibodies needs to be on some of these. And these include vitamin C, vitamin D, vitamin B12. They include such things as curcumin, astragalus, quercetin, and the minerals boron, selenium, and zinc and magnesium. In other words, you need to be taking some of these to try to stop future reactivation. So you put your finger in the dike, you stop future problems, but you still got your current problem. I now recommend that everybody who has these high antibody titers take monolaurin. We're not certain what we think it does, but we have enough people reporting positive results that we think it cuts down some of the multiplication of the virus in the colonies. We're not 100% certain how it works, but monolaurin is becoming very popular. Now, the thing I want to close this session with is the drug ivermectin. Ivermectin may be the most popular new drug in the treatment of adhesive arachnoiditis. People are starting to use it everywhere. Do I support it? Absolutely, I do. Why? Ivermectin is starting to be, apparently, looks like the only drug we have that may eliminate the colonization of the virus actually in tissues like the arachnoid membrane, or maybe even the glial cells in the brain. So I do support and advocate the use of ivermectin. Now, how should you take the ivermectin? And the way I'm recommending people take it is this. You take 9 to 12 milligrams a day for 21 days. And then at the end of 21 days, if you're feeling better, your pain's less, you're feeling better, you got more energy, your bladder's working better, your legs are working better, then go on a maintenance dosage of about 9 to 12 milligrams once or twice a week. In other words, you take a 3-week trial. We've had no serious side effects. I do want to tell you something about ivermectin, however. If you start the ivermectin, you may notice in the first week that all of a sudden you're feeling kind of queasy, you're sweating a little bit, you got a headache, your temperature may go up a little bit. That's a Herxheimer reaction. That means you're killing off the virus. And so don't be too concerned about that. In fact, that's good. You're getting rid of the virus. At any rate, what I did want to introduce tonight was the fact that if you have these two major antibodies to Epstein-Barr virus plus adhesive arachnoiditis, we are highly recommending a prevention program of vitamins, minerals, and herbs to stop future reactivation. We now really believe in monolaurin, that's a coconut oil derivative, and we think that a 21-day trial of ivermectin is in order, and that we're highly supportive of this. So that's one of the new things I'm bringing here tonight. I'll be talking about this a lot more over the next year, but I'm going to sign off on this right now. And each session, I'm going to hope to have a case of EBV and maybe some of these others, because we do think that the treatment of the Epstein-Barr virus is critical. And again, I want to close with one last statement. If you have adhesive arachnoiditis, we do believe you should have the blood test just to document in your own mind that you do have elevated antibodies to the virus. Incidentally, the antibodies do not go down even with ivermectin treatment. They stay up. We're happy to consult their arachnoiditis hope on these cases. But again, when they're talking about ivermectin all over social media and in places today, I want everybody to know that we are behind it and we think it's perfectly safe and worth a 3-week trial. Jamie, with that, I'm going to turn it back to you and turn it over to Mark and you to finish out the program. I'll sign off till next week. Good day.
Excellent. Thank you, Dr. Tennant. That was so wonderful and very, very interesting. So informative. We really appreciate you. Dr. Ibsen, are you out there with us?
Yes.
Good, good. So good to see you. And I wanted to see if you would like to share a few things tonight, if that's okay.
Sure.
I hear that there was, well, as we all know, the conference in Colorado, I hear was absolutely astounding. And I'd like to hear more about it. And I think several others would like to as well. You're free to speak on whatever you like too.
Thank you.
Thank you.
So I attended the conference in Westminster, Colorado at the Marriott. There were, I think, 52 people there with adhesive arachnoiditis. So it was strictly directed to adhesive arachnoiditis patients. And we have patients with other chronic illnesses, but there's an overlap in the treatment anyway. So it's worth talking about. The thing I want to point out about the conference that was shocking to me, first of all, the professionalism of the conference, its organization, the literature given, the amount of care given to the conference attendees. Imagine imagine all of you in pain, and you decide to go to a conference about it. The prominent thing about walking into this conference room is the front of the room is set up in theater style, 4 rows of 4 to 8 chairs. The back half of the conference room is set up completely different. There's 2 very large round tables so that everybody in wheelchairs can have a table to sit at. This is an obvious thing to do, but what was so impressive about it is the people attending this conference, I don't know, they must have gone through some machine, some de-resentmenting machine. I saw nobody there with resentment. I know, and everybody laughing, everybody welcoming people, everybody saying hello to their old friends and hello to their new friends. For example, I met Dr. Scott Guess 6 or 7 years ago. I met him in person this weekend. And now I really look up to him because he's 6'2". And I didn't know that. And so, meeting many of you in person was just a thrill. And meeting a group of people who are focused on defeating this thing, focused on supporting each other and anyone else who's in chronic pain. focused on self-care, number one, and improving care for others, number two. It is said that there's only one thing that generates compassion in human beings, and that is suffering. This is why teenagers aren't particularly compassionate, because they haven't suffered very much, except for the teenagers who have. And if you notice, teenagers who have suffered are compassionate. Take your kids with cancer, etc. So one of the things we can all remind each other about is that, yeah, we've been through a lot. And we can either indulge in self-pity over it, and I've done my share of that, and everybody goes through that, but the sooner we give it up, the sooner you and I behave like Miriam or Dr. Tennant or Eve Blackburn or Ingrid Hollis or any of the many people there that, despite their pain and their agony, they're putting on a conference for you and me. And of course, our paragon of class in that regard is Dr. Tennant. Obviously not comfortable with talking on his phone. Obviously a stretch for him to give a lecture in the middle of the Dallas airport for us. And what you've got to admire about this guy is he is determined to wring every drop of knowledge and wisdom out for us, so that we are set to share this information way into the future.
It's wonderful.
I got a certificate of being, I am now a certified arachnoiditis educator. The thought crossed my mind that I have a new career to start. Let's see what they pay for that. I know we're all volunteers and we're not going to collect any money from our arachnoiditis education. But and I put this up here so I would remember it, and I just did. Everybody got a hat with Dr. Beak on it.
Yes.
And if you've seen any of Dr. Tennant's bulletins, Dr. Beak has a lot to say about adhesive arachnoiditis. And I'm just not a hat guy, so I'm going to have to, we'll raffle this hat off someday, and we'll get it signed by Dr. Tennant and me.
That is awesome. And we will, I won't say when, but we will soon have more than, we will have shirts and everything available.
Right?
It's taking a while, but it is happening. And so
Right.
that's in the works, very close. Dr. Beak and Nurse Rosie are, I think it's a phenomenal thing. And I know that if anyone had criticized that at all, I just want to say, to me, the heaviness of what was being taught in those books was lightened by those characters. It made it easier to digest, easier to grasp, and easier to understand in the little side notes with Dr. Beak. So I love that.
Well, who doesn't love a cartoon, right?
Right. Yes. Yes. And we will
and I like civil disobedience. Dr. Tennant doesn't, but I do. Okay. And I could see and feel it in that room. People who are taking their lives back as an act of civil disobedience. We're not going to let them kill us. We may be on our own, but on our own means with each other.
That's right.
And there's more and more and more of us beginning to pull on an oar on this ship.
Right.
And yeah, we may not have a lot of power, but we've got numbers and they're growing. And so If you feel rebellious and you're pissed off, then get well in order to quit them.
Absolutely. And thanks to you, we have Dr. Bison's characters ready to be on shirts as well. I think that the attitudes behind some of those characters, I would like to bring that out so that people can understand that that was a character in this book. Go ahead and buy this book, but also it will be a deeper understanding because it's coming straight from the person. I think it'll help a lot.
Thank you. And what I learned about this whole weekend is that Zoom is great. Zoom's better than nothing. But getting together and hugging each other, we got to have some more of that. I understand the next conference is going to be in Buffalo. I don't know when. Anybody know when? But it's, I'll be there. And let us all get there if we can. And if you can't, we'll find a way to record it or participate, or maybe make it into a hybrid of some sort so that more can participate. We'll figure something out in that way too.
Yes,
And
absolutely.
are there any other questions about the conference?
Actually, there were a couple of questions. They wanted to know if there were any like recordings of the conference and or any literature from the conference available. And I know I saw some videos on your Facebook that you took some videos, but
Yeah,
a couple
yeah.
people.
I did a video. I did like I think 7 different like 2-minute videos of Dr. Tennant to grab snippets of it. Scott Guest did record his presentation. I don't know what format we'll see that in. But we might want to reach out and see because it's a great presentation. And here it is. It's so great. AA is PC. And by PC, by AA, he's talking about adhesive arachnoiditis. By PC, he's not talking about politically correct. He's talking about palliative care. And the whole lecture was about how, of course, without a doubt, if anybody qualifies for palliative care, it's those of us with adhesive arachnoiditis. And those of us who have been unsuccessful in obtaining palliative care need to keep banging on that door because and he pointed out in the lecture brilliantly that if you don't have appendicitis or trauma, almost everything you're getting is palliative care. Like insulin is palliative care for the diabetic. There's no cure for it. The definition of a disease that requires palliative care is a disease that's not curable and that we just manage. Classic example and very parallel to what we're doing is HIV. There's no cure for HIV. If you don't take your antiretroviral drugs, your viral count is going to climb. If you take your antiretroviral drugs, you're going to live a full life. So is there a cure? No. Can it be managed? Yes. We got all kinds of diabetics managing their diabetes without a cure, but with medications that they absolutely need, that they can't thrive without. Sound familiar? That's what we have here. And CRPS, trigeminal neuralgia, Crohn's disease, they all are incurable. Well, Crohn's disease is relatively curable until you run out of colon or intestine to take out. And I have several patients that have had all the surgery they can have. They're out of guts to take out. You can't take any more out. Well, once you've reached that stage, that's palliative care.
That's right.
And the thing about palliative care that seems to be unappealing is there's no money in it. There's no procedures. It's just constant attention to self-care. It's meet with your care practitioner and your care team, develop new skills in taking care of yourself, learn new revolutionary things. I mean, I think the discovery of Epstein-Barr virus and its reactivation is going to get the Nobel Prize. I don't know who'll be on it, but that is that big a revolution. And our hero found that out for us and has shared that with us for the last year. Stunning stuff. Yes, it's scary that Epstein-Barr virus is is everywhere, and you can't prevent yourself from getting it. And you may have gotten it as a 2-year-old or as a teenager or some other time. But the key thing that he has learned is that we can manage that. Maybe the antivirals aren't going to work so well, acyclovir or valcyclovir, that sort of thing. That's the intuitive thing. That's what I've been recommending. So I've changed that after this weekend, and it's all ivermectin for me. In spite of all the controversy about ivermectin, we're finding out information that is new science that is helping us manipulate and minimize viral load. Sounds just like AIDS treatment to me. Okay, I have one more thing to share, and that is, this is just a personal thing. People are interested in what's going on with me. My grand jury subpoena appearance scheduled for Monday, I just found out today, has been postponed. So I'm a little disappointed because I was peaking for this. And, it's like peaking for a debate or finals or something like that. It's all crammed in here. I'm afraid some of it will fall out before I get a chance to speak. So the date has been moved to September 16th. So that's just a 3-week change. So, and I'm ready. I'm ready for this. I've been, it's sort of like, this is all political, right? So all I've been doing is preparing with this amazing coach. And from Denver to Helena, Susan grilled me and dragged me through a keyhole of tough questions about tough issues. And we have got this presentation organized. Throw shoes, buddy. Well, those heels can be dangerous, Bob. So I'll just say that I consider myself ready now. I don't know why this postponement is happening. Maybe eventually they'll just drop the thing. Okay, so maybe that's it. So that's news from me. That's all I have to share for tonight. Jamie?
Thank you. Thanks for sharing that. I have a quick question, and apparently I'm not alone. We have Donna and Emily and a couple of others who have asked. Basically, what I'm going to ask you is, does palliative care exist in America? I thought it was just my area, the area that I live in, that it supposedly exists and doesn't, but I'm finding out all across the board that people will be approved for palliative care. They will have the referral, they will go over everything, and then all of a sudden they're not eligible, or they just can't. For my personal situation, they visited my house and they said, you qualify for palliative care, you qualify for hospice care, but we are not comfortable with the medications that you need to contain your disease, to contain your pain, to relieve your pain. We're not comfortable. And so then she further explained to me that they don't do medication management in palliative care. And I didn't want to get smart with her, but I just kind of asked her, like, well, what exactly do you do? And other than being a traveling nurse's aide, basically. And she just explained to me that they can do this and that, but they won't. And my big thing for palliative was the fact that there was an offering of help for your family and spiritual needs, and the caregivers would get help within this. That doesn't exist.
There are people on this call that have been on hospice and it got better and then got kicked off. So that's an obvious palliative care case. Okay, you're on hospice, they do everything for you, they act like you're going to die in 6 to 12 months, and then you get better from the treatment.
Yes.
Well, that's not bad news, that's good news. So why would you fire somebody from a treatment that they're improving on and have nobody else to pick it up? So, all of our proud graduates of hospice, thank you for sticking it to them and not dying. But also, we have to have a revolution in how we define terms in medicine. It's just obvious that palliative care is broad and the services available in palliative care are minuscule. And, until that gets litigated, the number one thing to say is that we don't have and never have had a pain czar. There's always been a drug czar. Um, there's always been plenty of law enforcement people to make sure we, don't drink alcohol during prohibition and, all those kind of things. But because we've always treated pain, always, there's never been a reason or a place for people who aren't getting their pain treated to appeal to anybody. There's no appealing mechanism here. We've tried ACLU, we've tried Americans with Disabilities Act, we've tried the Innocence Project. We're going to keep trying all those things. But this is an incredible gap in our care. And speaking as the tail end of the baby boom, we need palliative care. And it's not being delivered. I mean, you can say we have third world palliative care if you want. I'm going to argue with you that it's fourth world, and that we just have to stand up for people who aren't ready to go. The problem with having chronic pain that's not terminal. I mean, cancer's noble, right? You're going to have this noble fight against cancer. Judge Frank Caprio died today. God rest his soul. Pancreatic cancer, one of the kindest law enforcement executive branch people I've ever seen, and he's now gone. But we can remember him by saying, let's use some common sense, which is not very common. And then, palliative care is like common sense. It's not very common. It ought to be everywhere.
That's right. And I did make once I saw that it was falling apart and that it wasn't gonna, I just did make the statement to her. I said, okay, if I do go through your hospice program and I don't pass away in your 90-day window, then are you going to drop me on my head? Oh, no, we would never. I said, oh, okay. So it does leave a patient in a state of, what do I do when they tell you you're eligible, that you qualify, but sorry, no soup for you.
It's gaslighting.
That's it.
How is this real? Make sense of this. Explain it to me like I'm a 5-year-old, et cetera, et cetera. And they can't be explained because there's no money, and there's a gap in conversations, and the people that are talking about it aren't qualified to be talking about it. Excuse my French.
You're absolutely right. This has been a great show, and I'm so glad we did this.
Thank you, Emily. Emily stated that she's gone straight to her primary care doc and said, I need this referral to this doctor. He's palliative care, and it worked both times.
Perfection.
So
Wow.
maybe there's something in asking for what we want.
Maybe.
And then if we don't get it, ask somebody who can give it. And if we're knocking at the door and it's not being answered, then sometimes we need an advocate. I don't know if that's an attorney or a legislator, or a palliative care doctor or a palliative care team to get somebody advocating for you. It's doable. We just have to make more noise.
Yes. And how do you feel about like if a person goes into an appointment, say with palliative care, and they don't have a person in person with them, and the doctor allowed a Zoom call, like an advocate to arrive to be there with them during a digital way? I don't know if that's even allowed, but how do you feel about that? Like, would you feel as a physician, would you feel like bad, like why do you need an advocate with you, or would that make you feel more comfortable? Sorry.
As a physician, well, I'm unusual, so I mean, don't go by what I say, but yeah, I'd say the way to appeal to a doctor about that is, this is going to make your life easier. No one comes up to doctors and say, this is going to make your life easier. They're just going to, we're used to having people say, well, it only takes a few seconds for you to enter this data. Go ahead and let's let the doctor do it. So now we're, unit clerks and inventory clerks and central supply and all besides providing healthcare. So the number one thing is to say, we can streamline this for you. We can get you the palliative care protocol requirements. We can check the boxes that our loved one fits that box, and then we can appeal to the insurance company so that they pay you for your time. People your doctor's got 5 minutes, maybe 10. I have an hour to talk sometimes, and I'm talking too long right now. I don't mind that conversation, except right now I'm too busy to have it. I can't. It's sort of like I can't prescribe and take care of the patients that need my prescriptions and advocate at the same time. Both are falling short. But I'm stretched thin. That's the great thing about being able to service a community that needs me, is I'm stretched pretty thin. Doctors are afraid of ivermectin. Doctors have been delicensed for recommending ivermectin for their patients. For the COVID, the controversial aspects of COVID. But let's kind of merge that together a little bit. I didn't prescribe ivermectin for anybody with COVID, but COVID's a virus that's related to the Epstein-Barr virus and the herpes viruses. It's an mRNA virus. And if we're now getting evidence that it helps with other viruses, that could open things up considerably. And I've always wondered why these people who peddle ivermectin for COVID, why they believe in it so strongly. And because I didn't have a direct experience of it, it's just a concept. And when you get an experience, it's like when you have pain, you understand pain better. And I've had some pain, which is the best training I've had for pain. I didn't get COVID, knock on wood. And I got a couple vaccines and, dodged that. So I didn't have to study it for me personally enough for me to know enough about it. So I'm open to learning much more about it. Okay. Where does Doc call it into? Do regular pharmacies have it?
So Doc
There you go.
recommended 9 to 12 milligrams
Yeah.
once a day for 21 days. And the first time I did it, I did have a headache and like flushing, like I took too much niacin or something. But the second time that I just did it, I had nothing. It was amazing with how much more energy I had. And I swear, I believe it helped with the neuroinflammation as well.
It does.
Thank you.
Wellness center, wellness something you can get the kit. It's an emergency kit in case something were to happen. Power goes out. It's a wellness kit. You can get it on Rumble. Somewhere's on Rumble. They advertise it there, and it's true because there's some ivermectin now that they know that we know it's good for us. It's not true ivermectin no more. So be careful of what you get.
Okay. Thank you, Brandon. And then the flushing that you experienced, Allison, that could very well be part of die-off. That happened to me with, I believe it was when we first started the KPV. And I think like by day 3, I said, if I feel like this tomorrow, I'm not taking this anymore. But the next day, it was day 4, and I was like,
better.
woohoo! I felt great.
Got to get it in your system good because it's like your body's not used to it, so it's got to get in there. It's like our supplements. We do that full week, and then we go down and skip a day, take a day, skip a day. For your tolerance build.
That's right. Yep, your body gets used to it. But that's right. Hydration is so important. I cannot stress enough. And the fact that we can drink too much water and become dehydrated. Yes, I just said you can drink too much water and dehydrate yourself by drinking too much. Dr. Ibsen, Dr. Lynch, please correct me if I'm wrong, but we need electrolytes. We need those vital trace minerals, preferably the 87 trace minerals that's in sea salt. So that's beyond important and it helps with pain. If you're dehydrated, you're gonna hurt. If you're more hydrated, your pain levels may go down. Mine do. I don't know about everyone else.
Yeah, me and my doctor discussed it, and he said, "Is there something to that? Because my wife is doing it." And I said, "Yeah." I said, "Get through that first week, and it's like a game changer for me." And he's like, he said, "Well, my wife swears by it. She's just like, it changed her life."
Yes.
Like, yeah,
Fantastic.
It's wonderful. Thank you. It looks like we're just about out of time, and I think we've covered everything that was supposed to be covered tonight. Dr. Ibsen, you did a fantastic job as usual, Brandon, everyone that has helped tonight. Thank you all so much. Thank
Sorry,
you
I
all
had
for
a
your
delay getting
questions
in.
too.
My stuff,
Don't
it's been-
worry. That's no big deal. We do
Yeah.
have a question from Bob. And is there an age limit on ivermectin? My uneducated guess I would say no, but that's my uneducated guess. I do not know. Maybe over 2 years old would be my guess. I don't know. Dr. Ibsen, do you know about an age limit for ivermectin? Can babies take it?
We worm kids all the time.
There you go.
My father gave it to me when I was a kid.
Okay.
Just go by weight.
Yep.
You have
Okay.
to do that by weight.
Perfect.
And you can
Perfect.
find the package.
Worm your kids.
insert-
They're little parasites anyway.
Yeah, I mean, you got
Parasites
pets,
with
you got
parasites.
You can find the package
80% of the
insert for the
population-
human pills
80% of
online.
the
Read it.
population is walking around with the Epstein-Barr virus, and
You're
you don't
right.
even know it,
Most
or you
people
know
have
they've
it.
had it.
That's right. Thank you, Brandon.
You can find the actual package insert for the human pills
Oh,
that are available by prescription. So it has
Okay.
all of those, all that
info.
prescribing information, and I'm sure it has, age specific
Brilliant.
details in it.
Excellent.
Brilliant.
Perfect.
I always look
Excellent.
up the dosage
That's right.
packaging material whenever I am interested in a medication.
That's so smart. That's something to not throw away. And Emily, I love what you said, and that you basically you went to your primary and you just straight up said, I need to see this doctor. He is palliative, and they just referred you.
Yep.
It was
No
wow.
problem. Both times. Twice I've done it now.
That is so amazing, and
As
that
long
gives
as-
so much hope.
As long as they don't have to do any research, they're happy.
Okay. All right.
No,
Hey, that's
and-
good.
I don't know. I'm very unknowledgeable about ivermectin, but it looks like it's available in tablets
Mhm.
on Amazon.
Oh, wow. Okay. Okay. So we just want to basically be sure that it's a reputable place, I think.
Yeah.
Yeah. Okay. But it does help. And I like Dr. Tennant said, he recommends it for every one of us. It sure can't hurt, I wouldn't think.
How do you know if it's reputable though?
That's a very good question. I would think that I wouldn't even trust reviews these days because some reviews are fake. So the way that I would go about it is mostly word of mouth is what I would go to people that I trust, that I know aren't going to BS me, and say, hey, have you taken ivermectin? If they say yes, where did you get it? And then go from there. And it's been shown that ivermectin and fenbendazole are being used in the treatment. I have to be careful with my wording here. Those are being used by people who have cancer, and many of those people have found those products to be helpful. We'll put it that way.
Okay.
Yeah.
Very good. Thank you.
You're very, very welcome. I appreciate you all so much. And man, this has been just a great show. Dr. Ibsen shared Wheelhouse again. Is it okay if I read it, Doc, or do you want to read it before we go?
So let's both read it.
Okay, here
We'll
we go.
compete.
Wheelhouse. I
I
stand
stand in the
in
wheelhouse,
the wheelhouse
of our humanity,
responding
responding to
to
reports
reports of
of
calm seas while
while
navigating
a
a
class
class 4
4 storm.
storm. And
And
I
I
know
know
that my shipmates
and I
are
are
on
on our
our
own,
own, and that we
that we will
will
weather
this
this
storm
storm, return to
Return.
port,
port and
and
have something to say
say to the
to the
shore-bound
shorebound
navigators
navigators who
who
kept
kept
lying to us
about what was right before our eyes.
us.
Thank you.
Thank you too.
Thank you.
Bless you, everybody.
God
Bye-bye.
bless you too.
Thanks, Dr. Ibsen.
God
Thanks.
bless us, everyone.
Love y'all. Thank
Love
you.
y'all.
Love you.
too.
Love
Dr.
y'all.
Ibsen.
See you next
Have a
week.
good evening.
Yes,
Have a good week.
you as well. We love you as
All
well.
right, guys, I try to get my picture up. It won't allow it.
Really good news. Real quick,
Because
Allison just shared
it's
$1
time.
per pill with insurance on Amazon for 3 milligram tablets. That's a
Wow.
start, you know. And Valerie, for you to say
Awesome.
that is, I can't believe you said that, but that was I'm not even gonna say, but for you to want that on your t-shirt, you ask and you shall receive. I love you. Mwah.
Yeah.
You all have a great night. God
Good night,
bless you.
everyone.
Thank you so
God bless you all.
much. I love you all and good night.
Yeah, God
Love
bless.
you. Bye
God
bye.
bless you
Yeah.
all.
Thank you all.
Thank
Have a good
you.
week. Bye bye.
See you next
Bye.
week. Ciao. Thank you.